Thank you for this invitation. I think it's a great initiative by Dr. Sharad, and I am sure the numbers will grow. And it's also a great privilege to present on this online forum. So today I will be talking about where would I do CTA after CAG. It's a rather controversial and complicated issue because, as we know from guidelines, CT is traditionally used in some situations, which I'm just going to enumerate. And when we have a lot of options in terms of imaging, I think as cardiologists, we must be very selective and also discerning which one to use in what situation, depending on the specific clinical question that has to be answered. Because there's a plethora of options, there are a plethora of good imaging techniques available in the market today. So we need to be a little discerning and make sure we're choosing the right one. Just a quick overview in terms of gatekeeping. I'm using the word gatekeeping as a allude to what tools do we need to do to make sure we are in the right direction before we proceed for an intervention or revascularization. So if you have a patient with a prior MI and significant LV dysfunction, the tools we would use would be either a dobutamine echo, a PET scan for viability using FDG, a SPECT using MIBI and NTG, or a cardiac MRI using gadolinium would be the options that we would use. And only if the patient has adequately viable tissue in the area of interest, then we would proceed with the cath angio and the intervention, either PCI or bypass. In case of a prior minor event or mild LV dysfunction or a borderline lesion, we would use either a dobutamine echo, dobutamine MRI, or a SPECT. This would involve either adenosine or exercise on the treadmill. And if the ischemia is significant, patient would then go to the cath lab and get fixed either by PCI, or if the patient has multivessel disease, get bypass. In case the patient has no prior event with a normal LV function, and you're here to rule out CAD, especially in an intermediate group symptomatic patient, or in an asymptomatic patient, but who has a borderline stress test, either a treadmill or a dobutamine, and you want to clarify, then CT is, that is where CT by guidelines is to be used in those two situations. And where you have a borderline stenosis, again, you would use any of the techniques that I've already alluded to. And if there is significant disease, then patient would straight away go to the cath lab, get an angio, and then PCI or bypass. So just to talk a little bit about CTA before we move on to the off-label and controversial things which I'm told to talk about today. We know that coronary CTA is easily available today, at least in the metros, a number of centers doing it. It's completely non-invasive. You just drive in and you drive out. The exam time is actually 5 to 8 minutes, but it takes about half an hour to get in and out because of heart rate control, beta blockade, so on and so forth. CT has a very high spatial resolution, and there is 3D imaging possible within a single breath hold. So the breath hold currently is anywhere between 4 seconds in the 256 slice scanner to about 8 to 9 seconds in a 64 slice scanner. 8 to 9 seconds in a 64 slice scanner. And obviously the main technological revolution that we have had is the ability to have multi-slice CT. The basic minimum would be a 64 slice, and it would go up to a 320 slice that Toshiba currently has. Now, what are the issues with CTA? Well, the first one obviously is radiation. But when we talk about radiation in today's modern scanners, in our lab at least, we operate anywhere between 3 to 5 millisieverts for a normal coronary case. It would definitely depend on the heart rate and the weight of the patient as well. In the 256 slice and 320 slice scanners, we are almost operating at 1 millisievert, or maybe in some situations 0.8 to 1.2 millisieverts, which is really, really good in terms of the kind of radiation that we are having now, being exposed to. Contrast, yes, you need iodinated contrast. You need to have a normal renal function. Calcification, again, an issue. Arrhythmias is an issue. Motion artifacts are an issue. These three, I would believe, are only relative contraindications or issues because we are now able to really see through calcification using good software and good iterative techniques. Arrhythmia, unless the patient has a very variable RR, you can get some very decent pictures. We are doing coronary CT for all of our patients who are undergoing AF ablation. So we do what is called as a LA map or a pulmonary venous map. And we do that with fairly variable heart rates. We get some very good pictures, and this is superimposed into the Carto lab, and it becomes very easy for the operator. The time taken to ablate just comes down, and the completeness of the ablation again becomes really, really good with this. Motion artifacts, you need to have a good nurse to teach the patient, walk the patient through the protocol so that the breathing artifacts don't come in. Now, in terms of applications, I'm just going to run through some of the things that we are doing. CT can now actually look at myocardial perfusion. It's great for coronary anatomy. That is what it has been designed for. We are looking at plaque morphology, and we are finding that there are some high-risk plaques that if we find, we can counsel the patient, aggressively step up the lipids, so on and so forth. Pulmonary vein map, I've just talked about it. Aortic pathology, again, in the context of the TAVR that we are all doing, CT is the must-have investigation before you move in and sort of select out the patient for a TAVR. We are looking at myocardial viability in some situations. Calcium scoring, obviously, again, we do in all cases, and it helps us choose the kind of patient that we can actually do. We are not limited by the calcium score. We look at not only the calcium score, but we also look at the density. We also look at whether it's central near the ostia or is it in the periphery. And that helps us take a decision whether we can go on with the contrast or we need to stop there and either do a MIBI scan, that's a nuclear scan, or we go to the cath lab directly. So these are all the various applications that are available by the traditional cardiac CT. You would obviously need a dual source or a dual energy CT that we have to do viability and perfusion. But with an average 64 slice CT, you would be able to do all the rest. Now, the chief areas in CT would be luminal imaging, and we've become pretty good at it, very close to what the cath can offer. Plaque imaging is where we go the next step. We're able to look at the wall where angiogram is limited, and we can add that to the calcium score and re-risk stratify our patients. We're able to look at ventricular function, and I'm going to show you an example of that. And we're also looking at myocardial perfusion and viability. The limitations we have gone through, but I'm just going to list them out so that we have an idea before we move into these cases. Very fast and very irregular heart rate would be a strict no-no. We need to get those heart rates down, and as cardiologists, we are very good at using beta blockers, ivabradine, and diltiazem, and I've not had really a patient over the last 10 years whom I had to really refuse for a rapid heart rate. High calcium scores, again, not limited by the number. I have done a couple of patients with more than 1500. It just depends on the skill in which you can use to manipulate your software and get the details out. Stents, we're not good at less than 2.5 diameter. Peripheral distal stents, it will be very difficult to really tell what's there in the stent or the occlusion there in the stent. Contrast, again, we're limited if the creat is more than 2. Small vessels, very tiny vessels, again, would be difficult to image. Obese and uncooperative patients, obviously, that would be a problem anywhere, but weight has really not been an issue with us. And radiation exposure, as I said, we are trying to get closer and closer to the one that's the gold standard, 1 to 2 millisievert. Right now, we are between 3 and 5. So just going on to the cases now. As I said at the outset, this is off-label indications and would not be in tune with the guidelines. but since the topic is such that I'm going to be talking about that, and I'm sure there will be some controversies. So it's a 57-year-old female presented with worsening shortness of breath, class 2 to 3, and atypical chest pain. The symptom has been more of breathlessness rather than pain. She's got risk factors. She's hypertensive. She's had known CAD, had an old anterior MI. She had a PCI to LAD a couple of years ago. Clinically, there were signs of heart failure. And on this basis, patient was diuresed, and when stable, an angiogram was done. Now, these are the angiograms. So as you can see, the RCA is completely normal. Sharat, am I sort of audible and clear?
Yeah. See, I'll read out your angiogram. RCA is almost appearing normal, right? Left system, see, I'm not able to see LID. LCX appears to be normal, right? So LID, I think in caudal, I'm not able to see the origin of LID at all.
Yes, so that's the whole point here. And in the top right hand corner,
there is something there, probably calcium or old stunt, I don't know, which is seen in alveocranial view which is probably appearing as the origin of LID. I mean, the proximal part of the LID. Is it the calcium or old stunt?
Yes, so I can see that clearly. The top right hand corner, if you look at, and I see where my mouse is. That is the origin, ostial occlusion of LAD.
Yes.
And that's where also the stent has been implanted.
Okay, it's a stunt.
So now, so now we had a little difficult question. The patient has an LV dysfunction. This lady has a lot of breathlessness. There's no clear-cut anginal symptom. We have an osteoproximal complete occlusion of the LAD. And we have the stent also there. So at least for an average sort of cardiologist, this would be an intriguing situation as to how to proceed. Now, these are the issues that came up with us. Do you want to do a PCI to LAD? Would you sort of attempt it? The second would be, would you like to have a look at viability in this patient? This patient has a lot of breathlessness, old MI, moderate LV dysfunction on the echo. So we want, do we look at the MRI and look for viability and maybe additional ischemia in the same area? Is it all heart failure because of the LV dysfunction? The third thing was, since the ostium is so difficult, stent placement, would you like to go with an IVUS? The issues here was, we're not even able to see the ostium, so it would be technically difficult. Again, an invasive procedure, cost, and again, we don't know viability. We don't know whether this myocardium is going to improve after we do the procedure. So,
if I leave viability, one more question I had in this angiogram is, see, the distal LAD is not visible at all in any of our views, either retrograde or antegrade, or there are no collaterals, and I'm not able to see any LAD.
Yes.
See, that is another situation where I want to know whether the vessel distally is good or not, before attempting anything.
Correct. So that was the issue here as well, because it's an ostial flush occlusion. We can't see the LAD anywhere. The RCA injection, despite being long, could not identify any kind of a retrograde collateral. So we were sort of blind to this. So we took the fourth route, and again, I want to label it's an off-label route. We did a CTA in this patient to really look at two things. One is we are good at looking inside the stent. We want to know what is there. Is it intimal proliferation? Is it thrombus? We want to see the distal vessel, if it is there or not. And also we really want to know how this myocardium is behaving. So after a complex intervention, you don't want to be left with the same LV dysfunction and no improvement. So we did a CTA. Just to put it to those who are still on the fence in terms of viability, and this is Almond's data, I'll just quickly run you through this. When you have viable myocardium and you keep the patient on medical therapy, you have a 16% event rate per year. And if the patient is revascularized, it just drops to about 3%. So the huge benefit of revascularization in viable tissue. However, no big difference if the patient has non-viable myocardium, whether you revascularize or keep on medical therapy. So if you're going to revascularize a patient who has non-viable myocardium, you're going to get the same result as keeping on OMT, plus the additional hazard of the intra-procedure risk. So just to put that in perspective, since we've had a couple of trials like the Stitch, which have not really shown much difference, we're not going to go into that, but just to keep everybody in the same spectrum. Now, these are the CTA pictures. I'm going to sort of walk you through them so that it's comfortable. The left circumflex and then branching out into a large OM2. You've seen that on the angio is nice, crystal clear, no problem. There are no plaques, no lesions. On the top right-hand corner, you see the RCA, again filling very well, and the branches, absolutely no calcium, it's fine. In the bottom two is the stent, and we get to see the whole stent now. We can even measure it. It was almost a 3 millimeter stent into approximately 28. And you can see here that there is a significant new intimal proliferation, the proximal, complete occlusion of the mid and distal portion of the stent, and absolutely no trace of the LAD whatsoever post-stent at any point. So completely occluded with thrombus-filled LAD in this portion. Dark or low Hounsfield unit is thrombus. There was no calcification. We went a step ahead and we looked, remember I said we are able to do dual energy. That is, we have a dual head camera and we can change the KVs to 100 and 120 or 120 and 140. And we're able to also image the myocardium. So you can see on the left top corner, there's a two-chamber view. The dark areas are not perfused areas. The orange is well perfused. This is the inferior wall, this is the anterior wall. And at the mid-short axis, at the pap muscle level, you can see there is significant thinning and dark areas here. And this is also seen more distally here. There is thinning, dark areas. And again, and a small aneurysm here and dark areas. So basically suggesting a complete lack of myocardial perfusion beyond the first diagonal, along with thinning and chronic changes of LV dysfunction. So here, just want to put into perspective that CTA is increasingly being used as a tool for viability. The images almost as good as TTC, as you saw that with MR, and you're getting these very nice images. The spatial resolution of CT is much better than the nuclear and PET techniques, so you're able to even see subendocardial scars. But again, it comes at a slight disadvantage of more radiation when you have to do the second run. And all scanners don't have what is called dual source or dual energy. So it would be difficult, impossible on a routine 64 slice scanner. So this is the data. It's early data, but it's there right now, and CT can actually do the job. So this particular patient, we did not subject her to PCI. We thought it was definitely too risky. We saw the stent. There was complete occlusion of that stent and absolutely no trace of the LAD. The surgeon obviously refused to go in because he could not see the LAD from any view. The CT also showed complete occlusion. So there's really nothing to graft. So she's been kept on optimal medical therapy and is currently doing well on follow-up with the usual diuretics, beta blockers, and ACE inhibitors. So Sharad, just want your opinion.
Yeah, as you showed, there is no viability. I have no experience of, CT angiogram for assessing viability. First time I'm hearing.
Yes,
Heard
Sharat,
and read, but
the
first
early
time
days. Yes.
yeah. I think, of course, it's a reasonable decision not to intervene in this patient. But I have one query, I mean, just to create interest. Say, for example, this case, you got the viability. There is a viable tissue, right? So by CT or, by MRI, if there is a viable tissue, but still you don't see the distal LAD, even in CT angiogram, what to do? What would you
Yeah.
do in that situation?
Really, Sharat. So we have more surgical experience, and the
Yes,
surgeons don't want to tread into those areas where they're not able to see the vessel.
yes,
Surgeons are increasingly using CT in patients like this in the city as well,
yes,
wherein patients have had angios, complete occlusion, no clear retrograde filling. So I get a lot of requests for, John, have a look at the distal vessel. I have one more case, which maybe I'm just going to, bring it up earlier to just look at the other side of the coin. I'm going to make it the second case now.
yes,
That will put things into perspective.
yeah.
Yes, so
I
CT,
think,
not the greatest of tools for viability, as you said.
yes,
We would do MRI as the first thing because it is non-invasive, no radiation. Our choice would be MRI, no radiation. And MR, obviously, at this point of time, much more data, much more superior spatial resolution with all the other advantages of mitral regurgitation, aneurysm, and everything that goes with it. But in this case, the peculiar thing, as you rightly pointed, was we're just not able to see the vessel. Now, without
yes,
seeing the vessel, to go in for a complex, this would be a complex intervention, would be quite hazardous and not a great proposition.
yes. Probably
So,
this is the first indication, which we can give to all our, participants today, that an invisible LAD in an angiogram, whether patient had a triple vessel disease, single vessel disease, before taking, decisions, I would say, it is wise to do a CT angiogram and try to explore how the LAD is. Even if you feel the LAD territory is viable. So if you don't see any LAD, I think probably it's very difficult for surgeon also to answer, on the table. I mean, I had one similar case, so where CT also not showed LAD. Then we did. It's almost like ostial total occlusion. We did an IVUS guided entry into LAD. Then I opened LAD. It's all diffusely diseased, till the end of LAD. We left that patient. We just did POBA and we left.
yeah, Sharat,
Okay.
before we have the questions, Sharat,
Yeah.
before we have more questions, I want to just present this case.
Yeah. We'll
Because
go ahead, sir.
other
Go
side
ahead,
of
sir.
the coin, and then we'll have
Yes.
a little discussion.
Sure, sir. Sure. Yeah.
Yeah. So I've moved this case up. This was my last case, but I moved it up to generate more discussion. Is a 54-year-old male, atypical chest pain, actually was on a pilgrimage to Tirupati, had this atypical pain, came down and then was seen by a physician. He's underlying diabetic, no prior cardiac history, clinical exam was normal, but he had an abnormal ECG. The echo also showed mild LV dysfunction, RCA territory involvement, and then he came to us for a further evaluation. And this is the angio. Coronary angiogram was done based on the clinical scenario, and you can see here there is a proximal total occlusion of the RCA. I haven't showed, but the left system is completely normal.
And no collateralization.
Yes?
Is there any collateralization from left system, sir?
No collateralization.
No collateralization. So distal RCA is not visible at all.
Not visible at all. PDA, PLVB not visible at all. Patient again had some atypical symptom. That's all. He neither has angina or anything. Left system completely normal.
Okay.
So in this case, we again went ahead and did a CT, and that's on your right.
Yes.
And this is, of course, the MIP image that we have, restructured and put in for you. And you can see the proximal total occlusion with the same branch. And you can see very beautifully filling PDA and PLVB here. I think this is the RV branch. And a fairly short total occlusion. What is very important here is not only the length, but also we could see that this was only non-calcified plaque with a little bit of thrombi. There's no calcification or fibrous tissue anywhere in between, suggesting a fairly recent possible occlusion. So this patient, we went ahead with the measurement and everything, and we went ahead and did the PCA to RCA with a good result. So just to generate the interest, would you do a bypass? Well, we didn't do, and you don't want to keep him on optimal medical therapy because you have a occlusion there. It's short. Patient didn't have much symptoms, but he had an ECG echo evidence of having a recent MI, and he's got risk factors. So we went ahead and did the PCI. So this is the exact opposite, the other side of the coin to what I showed initially. Showing that CT can really give you those fantastic images, and it helps the interventionalist really plan the procedure. The success rate of the procedure all can be fairly well planned before going in and doing anything. So I'll just open up this thing for discussion, Sharath, now that we have both the cases.
Yes, sir. Yeah. See, I feel, when I looked at the angiogram, sir, there is no filling of distal RCA. And as you said, even left system is not filling RCA. But when you see CT, artery is actually well filled. In fact, there is no negative remodeling. I mean, the size, everything is very good. So that says, is there any possibility that we may have to take some long injections in conventional angio and see?
Generally, Sharath, most of us, when we see this total occlusion, are generally taking fairly long injections.
Long injections,
Yes. The hazard of that is we shouldn't be taking too long injections because we'll get cancer. That's one. The second thing is we don't want to be competing with the people doing CT angio and increasing our radiation scores, which we are not reporting, by the way.
Yes, sir. Yeah, so my one take home with this is, though we can't see a distal vessel in conventional angiogram, we can still see a good vessel in CT angiogram. This is a good take home point. So because so far I'm just thinking, if it is not visible in conventional angio, you will see some diseased vessel distally. So my assumption is wrong. And second, I just want to see the RCA angio once again, sir. Can you show us RCA angiogram? I felt, the branching is there at the site of total occlusion.
Yeah, there is.
Yeah, but when you see CT angio, surprisingly, there is a good vessel. See, here it is looking like a blunt occlusion. So if I take, this scoring, CTO scoring, I'll push this patient into a blunt occlusion. But when we see CT angio, there is a good flow.
Yeah, so that discrepancy we have been having. In fact, I'm getting a number of, I'm getting a number of referrals now in total occluded vessels. I'm getting a number of referrals. I call it reverse referrals for especially LAD, more for LAD, but also for some other vessels, where with good software use and a little bit of iterative reconstruction, we can really piece together the distal vessel fairly well.
Yes, sir. And this is also my observation in intravascular ultrasound. See, wherever I tried IVS guided entry, because of invisible entry point in angiogram. And 90% of the cases, I have seen nipple in intravascular ultrasound. What I felt retrospectively from my experience of these cases, see, in a conventional angiogram, when you are injecting contrast, if there is a good flow into that area, you will visualize it. So most of the times in these patients, there is a stasis of the flow at that point, which you may not visualize in conventional angiogram, but which can be made out by CT angiogram, because wherein you will take CT angio after a few cycles of beads, and in IVUS it is a direct visualization of nipple, so we can see it. This is my constant observation in 90% of blunt CTOs. I will find a nipple in IVUS.
Yeah, it is just that the resolution of the conventional angio obviously is sort of limited, and by using techniques like IVUS, we're really beginning to see a lot of things that we were not used to seeing before.
Yes,
especially when it comes to stent implantation and other things. So tissue prolapse and other things. So plaque morphology and tissue characteristics are obviously much better with IVUS. And obviously now the recommendation has become very clear that you don't do a left main intervention till you have an IVUS with you. It's become almost as clear as that. Sharath, your take on that?
Yes, yes, sir. So, I mean, in such a case, with a blunt total occlusion, obviously I'll go with an IVUS. If I go antegrade, I'll go with an IVUS. And as you said, for LMCA, IVUS is almost a gold standard. So, and this is a nice case, which really says how CT angio will help you after conventional angiogram. This is another good indication.
I'm going to move on, Sharath.
Yeah.
So case number 2, it's actually case number 3. I've just moved up the last case. Is a 48-year-old lady with chest pain diagnosed to have an infraposterior MI and then given thrombolytic. This was obviously streptokinase in the periphery, and then referred to the tertiary hospital. Period which took about 4 hours or so. She had persistent chest pain on admission. And before we take these patients to the cath lab, we are invariably doing a 2D echo bedside at the ER just to make sure that we have the diagnosis, any mechanical complications are not there before we go in to do the primary or the rescue in this particular situation. So the 2D echo revealed the regional wall motion abnormality in the right coronary territory, and what it also revealed was a moderate pericardial effusion. Now, this is a subset I have been studying very closely over the last 2 to 3 years, and I have picked up about 12 patients where patients have had either a late presentation, delayed thrombolysis, ongoing pain, and come in with an effusion. I have a series of 12 patients, and just want to know from you, what would you all do in this situation?
Yeah, definitely. See, any patient, this is almost like day 1 presentation, right, sir?
Yes.
Effusion on day 1.
Yes.
Yeah, see, any pericardial effusion on day 1 of MI, you have to rule out cardiac rupture. So, contained rupture. Contained rupture.
Completely.
I have seen one data, because I had one patient with a similar presentation, MI, not thrombolized, came on next day, and we could see a massive effusion, and it was a contained perforation. Probably I'll send all those images to you, sir. It's a beautiful, CT and MRI. So
okay,
it's a perforation. Obviously, I have to rule out perforation in this case, cardiac rupture in this case.
Yeah. So just going ahead, I think Sharath really got the hammer on the head. Myocardial rupture or a contained rupture is something that we really need to look at in this subset. I told you I've been studying this group fairly sort of closely. The options which are generally there for most of us would be a T first. Remember, it is semi-invasive. Patient is having ongoing pain. Patient is obviously a little distressed. So putting in a T, and I've we have done a couple of Ts in the past. We have seen the regional one, we have ruled out mechanical issues, but I've never seen a T showing the actual site of the rupture. We get a broad sort of area, but we never find the site of rupture. So to me, we didn't want to look at that because semi-invasive, rupture site really not seen. So we let that go. The next is you want to do an MRI. Now, the MRI is great for rupture. In the first pass of gadolinium, you would see that leak of contrast. You would get an idea of the area of rupture, the LV function, any other mechanical complication, that's true. But remember, generally these patients are pretty sick. It takes me about an hour to have a good quality MR and another about half an hour or so, even with experience, to really interpret all that finding. I never get to see the coronaries. I've been doing coronaries on MRI about 5 years ago. And for the last 5 years, I really don't even look at it anymore because it just takes so long and CT is just, seconds away for us. So MR again ruled out. Do I want to take this patient to the cath lab? I think Sharath really put it very nicely in context. Definitely not. We've had an experience of taking such a patient to the cath lab. We have given the heparin before you get the, the catheter in. And when you're just engaging the vessel, there is asystole. It's obviously because there's a pericardial tamponade and, the patient has sort of really ruptured. Because generally what brings these patients to the hospital is a kind of a selection, as I would call it, a selection wherein some amount of thrombus gets in and occludes that little leak. So a small thrombus sitting there, contained rupture, and there's not much of leak going on, and that's the reason why they actually reach the hospital. Because in a complete through and through rupture, they're going to obviously not make it to the hospital. So definitely not taking this patient to the cath lab, because the first thing my nurse would give me before I put the catheter is heparin, and we know what happened. So we have been looking at this group with CT. I have 12 of these patients. 3 have died. 1 just waited for finances, despite me saying that's a rupture, and died overnight. The other patient left the hospital, went to another hospital because they were unhappy with the plan for surgery, and they died there. The third patient actually was my first patient, where nobody believed I could actually look at a rupture with CT. And nobody believed me, and the patient died. The other 9 patients or 8 patients, I've been happy to report, and we have sent this for publication, and I'll show you that. We have had a look at those ruptures and sent them fairly early straight to the CT OR, not via the cath lab, and they've all been fixed. So this is my experience. And I'm going to show you this index case. So CT we did. Just for those of you who are not very familiar with CT, the RA, RV, we don't give too much of contrast. All the contrast on the left side, that's LA, LV. That's the rim of pericardial effusion that you're seeing all around this patient. And this is the descending thoracic aorta. Remember, dissection always is on the cards when you have a patient coming in with that kind of chest pain. And, so no dissection, we're able to look at that. And now if you look at, this is again a coronal view, modified view. I've specifically taken this view to show you the effusion, and you can see the contrast leaking into the myocardium very clearly. This is not really apparent at once. This requires a little bit of practice and thing where you can actually isolate and give you this kind of a beautiful picture. So there it is in the infraposterior wall. You can see that nipple of contrast leaking into the myocardium. And this is a composite view wherein we are showing you the leak of contrast. Remember, it's never a through and through. It's serpiginous, very tortuous, twisty, going into the myocardium. The rest of the myocardium is absolutely nice and black. We are giving you the area of tear, which looks dark. We call it the decreased perfused area, because remember, it has been subtended by the vessel which was occluded. That is also surrounding this nipple. And most importantly, the holy grail of cardiology, we're giving you coronaries. and we are actually telling you that this has been a OM, or the first OM which came off the L6 has got occluded, filled with thrombus, supplied that particular territory, and there you have a rupture. So this is a composite view that we're giving you. Just for everybody's information, the rest of the coronaries were clean. So in terms of management, we obviously didn't look at PCI. I didn't look at bypass as well. And no medical management, obviously. Sent this patient directly to the OR and just had a pericardial patch repair and came away because I've clearly shown to you that there is severely decreased hyperperfusion in the area subtended by the vessel, and there is a little bit of thinning also at that point. So I told the surgeon not to really go ahead and graft that OM. The OM is anyway not visible beyond that point. So I told him to just put a patch and come out. So, we've had a couple of publishings, and this is just one of them, looking at free wall rupture by coronary CT. Sharath, over to you.
Yes, sir. It's a nice case, and it's a direct indication for CT angio. I mean, we don't do conventional angio. In such a case, conventional angio is not recommended. Yesterday we had one patient wherein, while doing angiogram, patient collapsed. Same patient with acute MI, mild pericardial effusion. He just collapsed. I mean, even before they entered into artery. So that's what exactly happens. It's always wise to go for a CT angio directly. But I have a couple of questions, sir, here. I have one case probably, in next session, sometime in the next session, I'll put that case. So it's a case with the, acute MI with pericardial effusion on day 1. But I did CT and MRI later on. That means, maybe, 3 days or 4 days later. So in cardiac MRI, I couldn't find any site of leakage. But there is a split in the myocardium. So in most of the sections, see, the LV myocardium is completely split from apex to base. And even RV myocardium is split. Mostly, I felt, it is a blood which is flown into that split myocardium and which clotted. And there is no through and through connection. That is the reason, patient survived. And we couldn't, there is, we can see discontinuity in endocardium, which I observed at apex. But otherwise, the most of the thickness of the myocardium is fine with this clot inside the myocardium. And we did CT.
Yes.
We did CT again.
CT? Yes.
Yes, CT. Yes, CT. We could see a kind of nipple at the apex. MRI we couldn't see anything. MRI, but we couldn't see. We could see the clot inside the wall. Wall appeared as if there is something inside the wall. I'll show you those images. I'll send.
Sharath. So, I mean, in my 12 sort of experience, I have stopped doing MR for these patients. I've just stopped doing. The reason you have very nicely highlighted. So MRI, number one, takes a lot of time to get a patient into the magnet. The patient is virtually unapproachable when he's in the magnet. You talked about the patient who, had a sudden event in the cath lab. And you can imagine what happens if it happens in the MRI. So the MR images for an acute rupture are not great. You have to have some very good software to really look at what I call the first pass run, which most people won't really see. The first pass run of gadolinium will really show that. And I have a picture, I'll share it with you. That's the only place where you will see the contrast leaking out of the cavity into the endocardium. It's not easy to see even with practiced eyes, and many times you'll just gloss over it. And the biggest drawback, you don't get the coronaries, to me, which are the holy grail of the next step for this patient. because without the coronary anatomy, no surgeon is going to touch this patient. So I have completely stopped doing MR for these patients. And day one, or at ground zero ER, I get a call, there's an acute MI, thrombolized or late presentation, chest pain ongoing, more than moderate pericardial effusion. We are just doing CT for these patients. Couple of them, we have not detected the rupture, and we've just sent them. Pigtail is okay, and then a patient gets a PCI and the fluid just gets resolved. So I am at this point of time pretty confident about the detection of a rupture. But yes, we do get those patients very obese, heart rates very high, patients in shock, and the CT images not going to be great. But when I was discussing this with some people this was in Japan last year when I presented some data at the ASCII meeting, they were of the opinion that echo with contrast is a better tool in that situation. But again, I don't have much experience, and you would never see the coronaries anyway in that group.
And another thing, I feel my case, even if you do echo with contrast, you don't make it out because the track is already completely sealed.
Yes.
Completely sealed. There is no leak at all.
In a sealed track, you're not going to find it at all. So that's how it is.
Yeah. And so, as you said, even PCI could be an option for these patients. I mean, do we have any data, where we can do PCI, something like that? Because in my case also, I did PCI. He's still alive. I have done almost, 5 months back. That patient is still coming for follow-up. So do we have any data, where we can do PCI in these kind of patients? Because in my patient, it is completely sealed off. So sealed off. And anyway, is a high risk for surgery. What exactly happened on third day? So patient started developing mitral regurgitation. So his mitral valve was normal. So he started developing mitral regurgitation and went into an acute pulmonary edema. Then we thought, we have to open. He had both RCA total occlusion and LAD, 99% lesion with a small LCX. That's why we thought, we'll just go ahead and treat RCA, LAD, and whatever comes, we'll accept it. So we did, and dramatically patient improved. MR became completely normal, and pericardial effusion, it never increased. It remained same. And subsequently, I think on 5th or 6th day, I discharged patient. Another question. See, you also said, we can do PCI if it is completely sealed.
Yes.
How do you decide, sir, this sealing, whether this rupture is sealed or not?
Yeah, so very simple. When I give the contrast, I don't want contrast leaking into the myocardium like this. So as long as I don't see that, I'm going to tell the interventionalist that, yes, you had a mini rupture, but it's nicely sealed up. As you said rightly, you don't want to be taking that case on day 0. You want to wait 48 hours, make sure things are fine. At that point of time, maybe I will look at contrast echo. I will look at an MRI to make sure what I'm dealing with. And if I don't find contrast leaking in those two techniques, I would possibly, if the anatomy is suitable, we can still go for a PCI, no problem. But again, not much experience. Rarely you want to get that kind of specific case where you waited and the patient came, allowed you to give so much time, and then do it. So obviously, this has not been studied very well. But your case is a nice illustration.
Yes, sir. Yeah, that's one thing, sir. Another thing, see, you said, pericardial, tapping. So I see, in this case, in my case, I'm very skeptical about doing pericardial tapping. So he was fine. His hemodynamics was fine. After PCI, he dramatically improved, and we shifted him to room within 2 days after PCI. And he had a massive effusion, but no tamponade.
Yeah, I think unless you have a patient with a tamponade clear cut, we don't want to be messing in that area with the pericardial catheter.
Yes, sir. That's what I felt. We have not done pericardial tapping for that guy. Because again, if I do pericardial tapping and if I reduce pericardial pressure, I don't know how this contained rupture behaves.
Yes, we've had not a very similar experience, but that is also the hypothesis we have, that if you're going to suddenly decrease the pericardial pressure, remember this pericardial effusion is giving a nice tamponade on that area and allowing clot to really form. And if it suddenly goes away, there is a chance that you will have a possible leak again.
Yeah. And my case, I'm watching still is a effusion actually is resolving. It is almost 3 months. Still effusion is there. So it is just resolving. I felt, I'll do pericardial tapping if it continues beyond 3 months. Because by that time your healing and fibrosis, everything will be done. So probably, I felt that is a safe time to intervene. We are yet to do that. So I think he'll come next month. I'll present that case sometime in this forum. I'll show all his echoes, MRI, CT, and what we have done. I'll show serial echoes also of that patient.
Sharath?
Yeah.
Why do you want to tap that patient after 3 months if there is no tamponade anyway?
I'll show you the echoes. The effusion was massive.
Was massive, okay.
Massive effusion, but there is no tamponade. Again, it is very unlikely in an acute situation. Such a massive effusion, without much tamponade.
Whether he was kept on any other medicines like colchicine?
Anyway,
Post MI pericarditis.
No. I have not used any medicine for him.
Right.
It is clearly a perforation. It is not pericarditis.
Right.
I don't know. Colchicine has a role in these kind of pericardial effusion.
Could this
There is a role in long standing, but in pericarditis.
would it lead to constrictive pericarditis if you leave it like that?
Constriction?
Is there a chance that they may go into constriction if you don't tap? Could there be a reason?
Yeah, I don't think that is a reason. Just because it is massive, I'll show you. when I show those echoes, you will understand how massive it is. I can say it is 2 centimeters in posterior, in plots. The posterior measurement is 2 centimeters.
Okay, right.
Now you can imagine.
Yeah, we have a case like that.
Okay, I'm going to move on because of lack of time.
We don't know the prayer.
So, as a 58-year-old lady presented with chest pain on exertion, CCS class 2, diabetic hypertensive, and in view of the age and risk factors, angiogram is performed. This is the angios. Is a right coronary injection. It's fairly normal. This is the ariocaudal view, the left side, you're seeing the circ, left main and circ. AP cranial view, you can see the LAD. So these are the 3 views. And we took an iliocaudal view. So, Sharath, want your opinion on this set of angios?
Yeah, sir. I would like to go through it again, sir. All the views.
I'm going to run through it again.
Yeah, bit non-selective angiograms. So we are just struggling to see the,
Yes, I agree with you. RCA.
RCA is, it is filling till the distal part, but it looks there is a lesion in the proximal to mid RCA. But I don't know the severity of the lesion.
Yes.
And it is flowing. I could see PDA and PLs also. It is flowing, but not so clearly.
What about the left system?
Yeah, see LMCA, I am not able to see completely. Probably that there could be some lesion in LMCA. That is the reason your catheter is not entering into LMCA. And there is definitely a lesion in ostial LCX. I feel. But LAD, yeah, maybe ostial LAD, there could be some lesion. It could be something like an LMCL lesion extending into LCX and LAD.
Yeah. So that's the sort of trend that we also got. But based on these pictures, we were not very comfortable
Yeah, it is
in terms
very
of
difficult.
revascularization.
It's very difficult.
So pictures not great. There's something happening in the LM, LAD, L6 bifurcation, not very sure. We had some issues with the catheter going into the left main, damping both in the right and left, and that's the reason. And the high heart rates, patient had a little bit of uneasiness, so we tried to just get out. So just want your opinion based on these angios. Would you be doing anything?
No, not at all. It's very difficult to take any decision on this angiogram.
Yeah. So what next? These are the thoughts that went through us. I'm sure you have your own, but LMCA to LAD inconclusive for significant stenosis despite repeated views. We're not sure the damping is because angle of catheter or a lesion there, but in view of a possible significant stenosis, as seen by the haziness that you saw, little bit of damping, patient symptomatic, we thought we would like to avoid a stress study, which would have anyway, we would have thought of if we had a patient with a borderline other kind of lesion, mid LAD, mid RCA, etc. Obviously, we have had patients, having issues on the treadmill. We in fact lost a patient during a MIBI scan a couple of months ago. So we're a little scared of that. So we really need good anatomical confirmation of the lesion along with plaque morphology. So that's what we wanted. And since you had similar thoughts, in view of this, rather than going with the stress test, either dobutamine, MIBI, or whatever, MR, we went ahead. These are the thoughts that we had. And then whether to go for FFR, which is the gold standard in terms of left main lesion assessment, or we want to do IVUS. We know in left main it's great for the positioning and treatment, but in terms of diagnosis, we know that a 58-year-old 5-foot lady has a different left main compared to somebody who is a 6 foot 4-inch 42-year-old male. So the so-called IVUS measurement, I think, is at 4.5. Can differ. And this thing was brought out by one of our Japanese investigators even at CSI. But leaving that little controversy aside, invasive cost and issues of even getting the guiding in was a problem. We didn't want to do a stress test. I already told you about that because left main lesion, and we were a little worried whether we would cause any plaque rupture. So we went ahead, and this is our thought process. We would do a CT, we would get a stenosis, and we would get plaque morphology. That would be important in case you are attempting a PCI, and you would also get the regional wall motion and other things that are also there. So these are just two cases off the bat from my lab. These are not the same patient, but just to give you an idea of how I've used CT in these situations. So the top left-hand corner is the angiogram of a patient. And you would agree with me that there's a questionable left main ostial stenosis. Again, we had issues about quantification. We did a CT on that patient, and you can clearly see here a non-calcified plaque, that's a lipid-rich plaque, sitting right there at the ostium. And this is another patient, again, left main borderline. Many of us thought, this left main was important. It definitely looked a little above 50. What do you think, Sharath, about this patient? It's just a still picture, but what do you think?
It looks like a significant lesion.
Yeah.
Angiogram.
So, yes. So we also thought that. We did a CT, and the left main is wide open. There's a CT image of this patient. The left main is wide open. So with this little bit of experience with CT in these particular cases, we went ahead and did a CT on this patient, little high heart rates, little anxious person, so not great images, but you can see the RCA is pretty clean here. Nice looking RCA, no problem. And here was the problem. Right from the aorta, you have a calcified plaque snaking in into the left main and also in the osteoproximal LAD, and the rest of the LAD is looking pretty good, looking pretty significant. I've just blown this up so that you get an idea of the plaque and the plaque morphology. A little bit of lipid material also ensconced between the two calcified plaques. It's a whole block of calcium there. Again, just to put that in perspective, the left main plaque coming in from the aorta, literally extending into the LAD, very significant lesion with a little bit of lipid-rich plaque. We call that a vulnerable plaque. And you can actually see the proximal LAD diameter really down. I think, Sharat, you already said that, just before a large diagonal coming off and this block of calcium coming in from the left main. This is also just a blow up to sort of give you an idea of the lesion. And again, you said very rightly about LCX, very tight osteoproximal stenosis of the LCX, just coming off the left main with calcium and little bit of lipid-rich material there. So basically, again, just to put that in context, it's a blown-up image of the LCX coming off. And so management, definitely no PCI for this patient. Highly calcified lesion, left main extending into bifurcation. Obviously, no optimal medical therapy, but we did offer bypass Lima to LAD, RA to OMN for this patient. Sharat, over to you.
Yes, sir. So, yeah, obviously, in a patient, where we are not able to see the vessels, epicardial coronaries properly, I would directly go to CT angiogram for any reason. I'm not able to hook. See, sometimes we may not be able to hook coronary also. Many times it happens to the right coronary artery. So due to abnormal origin. So in these situations, it is, I would rather struggling in cath lab, I'll do a CT angiogram. And in this case, it's before you joined, sir, to the meeting, we had a discussion. I asked people, have you ever had a situation where you want to do a CT angiogram after conventional angiogram? So there is a data in JACC about case reports, especially on LMCS stenosis. So if you find an LMCS stenosis and rest of the coronaries are normal, so and patient is borderline symptomatic. So I would, in last 2 years, I had two such cases. I would directly go. Despite having a good cannulation of artery and good injection, and taking injection even after NTZ and diltiazem, whatever vasodilator you want. Despite doing angiogram after vasodilator, I would always recommend in such a patient's LMCS stenosis with the normal other coronaries to do a CT angio. There are many case reports in JACC where people did bypass surgery. In fact, a few patients underwent emergency bypass. 6 months later, when they did CT angiogram, his LMCA is normal. So as you showed in your second case, where it is appearing very tight lesion, but when you did CT, almost there is no lesion. And the second thing, see, you discussed about options in this case, IVUS or FFR. I would do IVUS or FFR if patient is symptomatic, had significant symptoms or ECG changes, and patient is ready for revascularization on table, then I would consider FFR or IVUS. If patient no symptoms, no ECG changes, and not ready for simultaneous or ad hoc intervention, I don't consider FFR or IVUS for these patients. But if they I would consider. And again with IVUS, there is a fallacy. Wherever, see, if the lesion is extensive on complete, entire LMCA, in this case which you have showed, the lesion is extending up into LID and LCX. So in such a cases, IVUS will really help you. But if the lesion is only ostial, again IVUS will go for a toss. See what exactly happens with an IVUS at an ostium. See, at ostium, IVUS takes a oblique sections of the artery. So you don't see the complete artery in each frame. So that's the reason it's very difficult to measure even LMCA area. I have a good number of cases where we did IVUS in LMCA ostial lesions, but I couldn't get a section where I can take a minimal lumen area. So again, IVUS may not help in isolated ostial LMCA lesions. But if the lesion is extensive, yes, it may help. But the question is that luminal area 4.9, which is again difficult. That again depends on patient weight, height, all that stuff. So that is one question. Over to you, sir.
Yeah. Okay. So yeah, the Japanese author, I think she was a guest speaker. She said she would sort of prefer an FFR in a case like, as you said, if there is a discrete lesion and you want to do something on table, she would do an FFR, confirm, and then go ahead. And she also did have some experience with doing CT in the other group where, you have other lesions, patient not ready, and then you would do a CT to confirm and then go ahead. Similar to what you have been saying all along. But just to tell the wider audience that CT is a great tool. You can see these two cases. There are two extreme cases from my lab which I've taken, showing how beautifully the ostium can be really looked at section after section in a very safe and comfortable way, rather than you sweating it out in the cath lab and worrying whether the IVUS is in or out and things like that. So that's just my sort of take on it. So I'm just going to move forward, and next case coming up is a 57-year-old lady, breathlessness increasing, almost become class 4. She's an abnormal ECG, LB, BB, QRS interval is now 154. She's been followed up medically, and now even despite OMT is pretty dyspneic. She has a dilated LV, significant dyspnea on the tissue Doppler, tentatively planned for a CRT. So she's 57. I didn't put in that she's also diabetic. So the normal thing is we went ahead and just did an angio. This is a still picture of the left system. Looks pretty normal. I'm not really worried about the branches here, but at least LAD, LCX, OMs are fine. The RC also looking okay. And then we sort of came out, normal coronaries, near normal coronaries. You want to do CRT. Now, suddenly the thing came as we didn't give a long enough injection to look at the coronary sinus and the coronary veins, because that is extremely important today when we're doing CRTs for a wide number of patients, where we are getting into trouble intra-procedurally because of valves, because of very tortuous veins, and it just makes the whole procedure very difficult. So what do we use now? TE, well, I've never seen coronary veins on TE. MRI, I've been looking at MRI because all our CRT patients come via the MRI route. We look for viability. We want to rule out an ischemic heart disease on the MR. And then we are also looking for dysynchrony to corroborate the echo. And what is very important that we look on MRI is the absence or presence of scar tissue anywhere. If it adds up to about 30%, you would consider a defibrillator in those patients along with the CRT, and specifically looking for delayed enhancement in the posterolateral wall, which would be a real bummer in terms of being a responder or not. So if you have a near transmural scar in the posterolateral wall adjacent to the posterolateral vein, which would be the ideal location for putting in the lead, then that lead is not going to pace. Now, many people, and there are reports of using multipolar leads, but you just leave that controversy aside, and we have found that many of these patients turn out to be non-responders. So MRI is a great tool. We are using it regularly, but I've been trying to tweak protocols, but really no good coronary vein visualization. So anyway, since this was part of this, in this particular patient, we did the CTA for this patient. Three things we got. So this is Cta Pictures. I have the wall motion abnormality showing the very nice dysynchrony, but I'm not showing it because I thought there'll be issues uploading this. So I'm just going to show you still pictures again to confirm what we've already been discussing. Dilated significant LV dysfunction, dilated left atrium, all views you can see a global thickening or thinning. And what is very nice to see is you got the coronaries and you got all the veins very nicely visualized. The middle cardiac vein, that's the coronary sinus, no valves. And I'm following the sinus right up here before it becomes a great cardiac vein. And you will see here that it beautifully branches into a very nice posterolateral vein before it goes ahead and becomes a great cardiac vein. I've not shown that because it's not of interest to us. And you can see a very nicely non-acute branching posterolateral vein. And you can see that here as well. Coronaries obviously visualized very well in the same sitting. And this basically means you're going to have a really clean run with that LV lead, no valves anywhere in between, and the angulation also nice to put in that lead. The lead also, we have shown that the vein actually goes and sits on the posterolateral wall, which was actually the farthest away from the septum in one of our cine tracings. So just the additive use of CTA in these patients, where you're going to get wall motion, you're going to get some element of dysynchrony, and you're going to get scarring. We're seeing scarring on CTA. I already showed you data on scarring. Most importantly, you're going to get the coronaries because you really want to rule out a CAD, especially in that subset. And obviously, the real the gold that we're going to find is the very nice coronary vein branching pattern, actually identifying the right vein where you would like to put that lead, the whole path to that vein, the presence or absence of valves, and also the presence of a very acute or very tortuous posterolateral vein, and all in all, leading to a very good procedural success acutely and long-term being a responder. Over to you, Sharad.
Yeah, I mean, this is a nice case, sir. It's an eye-opener for me. So wherever I send a patient to CRT, I mean, I have to take a long injection of angiogram. So far, I'm not doing that. I don't know how many people are like me in our participants.
You're not worried about the EP guys getting all the radiation, that's why. It has really tremendously brought down the procedural time for us in our experience.
Yes, sir. I mean, it's an eye-opener for me.
So coronary artery and vein, we're getting good at this. It's a little tweaking of the contrast, little tweaking of the timing where you want to inject. And remember, these are pretty sick patients, big LVs. So I have a time on my hands trying to make sure that, we have the right amount of contrast, makes enough contrast, and also making sure patient is safe on table and then getting these reconstructions. It has made me really relearn my coronary venous anatomy. So that's how it is. But we're giving a one-stop shop for the EP guys, both in terms of scarring, in terms of dysynchrony, in terms of coronary artery anatomy and coronary venous anatomy. So I think it's a nice kind of thing to give them this kind of information. Makes life very easy in the cath lab after that.
Yes.
So I'm going to move on from here. And this is another case, 57-year-old lady, increasing angina since a month. She's post-CABG 2010, so 8 years ago, no details. And just to make that a little more blunt, 40% of the patients who come into my lab post-bypass just don't carry any paper. Either the house has been changed, the house got burned down, someone else threw it away. They just don't come with the bypass details. So it's quite a hell of a situation, actually. But anyway, leaving that aside, the electrocardiogram, not much changes. Echo is good, LV function. So the plan was to do an angiogram. It's taken up by one of my colleagues somewhere else. This angiogram done. This is the right injection, still pictured again. Some mild abnormalities. I'm sure you agree there's no significant stenosis. But this is the picture that I got. Now this is the left main, left injection. Circumflex looks fine. You can see that there's a very tight 99% osteoproximal LAD lesion, diagonal coming off that. So we don't have details. What was the original anatomy? We don't know. So my friend fished around. This is the AP cranial view. You can see that tight lesion. I think it's osteoproximal LAD. Circ looking good. And well, he fished around. I don't have the Lima picture, but the Lima wasn't grafted. He just injected the Lima and there was no connection anywhere. So pigtail and everything done, really couldn't make out. This was the only thing he thought was a possible graft, but you know, this could be anything. And that's it. So any comments from you, Sharad?
Yes, sir. See, first of all, we had a discussion last month's session was like graft angiogram, taming grafts. So that was our session. In that session, we really discussed about this kind of situation. See, wherever I don't have data of grafts, straight away I'll go to CT angiogram. I don't try to even do a conventional angiogram. So whether a patient had a if patient had a class 3 angina, obviously, or a patient had an ACS, so obviously I'll go ahead with CT angiogram. That's the first thing. And second, if we have videos, see, we have analyzed in last session few videos of my patients like that, where I couldn't hook grafts, but I could take native vessels. There, one sign which we can observe is a competitive flow. If there is no competitive flow in distal coronaries, I just say, all the grafts are gone.
Yeah.
So, but we have static pictures here. I think it is very difficult to analyze that.
Yes. Yes. In fact, I have an RCA picture, but I'm not going to waste your time to upload it. So this is the picture we got. So he sent this patient to me and said, John, just see what you can do or what you can find. I just want your opinion on the RCA. What do you think?
RCA looks fine. This image, see, there is only mild lesion, maybe around 40%, 50% proximally. We don't know about the pressure data because there is a damping, all that stuff we don't know. And next, in fact, the vessel looks ectatic in between. So it looks around 40 to 50% lesion. And I couldn't see any competitive flow downstream, though it is a static image. So many times you can observe if there is a good graft, you don't see the distal vessel so well. If there is a competitive flow, I don't see, distal vessels so well. So I feel, that the graft is gone even for RCA and also LAD.
Yeah. So,
and also LAD.
I've had a look at the videos myself and I agree with you. There's no competitive flow in any of the videos. We had a doubt about ostium, but just based on this picture, we thought it was just borderline, if at all. So that was our take on that. So we did the CT. I would also agree with you at this point of time. I'm recommending to all my colleagues who work with me, whatever the situation, you have a patient post graft, just send the patient to me. We'll do a very nice data set for you. And it just makes life so amazingly easy, not only for the operator, but for also the patient. So we take typically about 8 seconds to scan them, or 9 seconds, if you will. And you have a beautiful data set with all the grafts correctly, named, nomenclature, and we really know what to do and where to go about it. Incidentally, my dad is post bypass about 10 years, and then he was having this symptom. So we again went ahead, just did a graft sort of CTA, and we saw that the RCA graft had closed and a severe osteoproximal RCA lesion, and all the other grafts were fine. So we just did PCI to osteoproximal RCA. That's it. We just didn't touch the grafts at all. So, I mean, that is the level of confidence that we now have with the imaging system. So I would echo with you the same sort of thing that we've been talking about. So issues about CAG, no idea about the grafts. RCA ostium was anywhere between mild to moderate, not sure. So we went ahead and did CT, and this is one of the great indications for CT in CAD, you know, because the grafts are extra cardiac, they don't move as much. So you can really get away with higher heart rates and not very good scanning. It's a less sort of, you know, demanding than you would do with a native coronary. So coming back to this patient, you can clearly see here that this is a nipple here on this side of the aorta on the right side. That means there was a PDA or distal RCA graft. It's occluded, ostial occlusion. I don't find these things anywhere else. And I've had a look at the Lima and Rima. Both have been ungrafted. They're not grafted. They're not grafted. So that information I have. No other graft seen. These are all the great arteries that are coming off. I've just cut them to give you this view. And that's the only graft that I saw. That's a graft to PDA possibly. And I just would like you to have a look at this portion that is the RCA ostium. And we're going to get you more pictures. So this patient apparently had only possibly a PDA graft, and the Lima, Rima still are not connected. They're ungrafted. And this is the RCA ostium. And to my surprise, this patient had a very significant osteoproximal partially calcified plaque with some lipid areas here, fairly significant. You can see that even in the VRTs, it's quite a shocker to me actually. And that is also possibly the reason why he was grafted in the first place. So the rest of the RCA, as you saw rightly, was nice, normal, little bit ectatic segments, a sprinkling of calcium all over, but a very significant osteoproximal lesion. And as again, you have seen the left main normal, and there's an osteoproximal, very significant lesion mirroring what I showed you on the cath. Here it's a non-calcified lipid-rich plaque. That would be a vulnerable plaque from our side. And the rest of the LED pretty good, nice and graftable. And you can see the circ is also absolutely clean. Echoing what you said about, you know, no competitive flow means basically, you know, that the graft is closed. Well, here it's a nice circ and OM. So yes, so we went ahead and we planned a redo bypass for this patient. Incidentally, when we do the CT scans for these patients, we look at the separation distance from the sternum to the RV, sternum to the graft, if at all there are any. We also look at patency of Lima, Rima, adequacy of Lima, Rima. So all this information is given to the surgeon. Sometimes he sits with me because we can really cut through from bone, sternum and go in, measure distances so that he's comfortable when he's doing the redo cabbage. Over to you, Sharath.
Yes, sir. Regarding treatment,
just for discussion. Treatment, yeah. Just for discussion, not.
Okay, I'll leave that part. Yeah, I'll leave that part.
I just put it there for the, you know, just for everybody's involvement.
Yeah, okay, I'll leave that part. See, these grafts, and I'm surprised, only right graft is there. Yes. There were no grafts given to left side. So, yeah, it's okay. And second, whatever we have discussed, that competitive flow, that is a very important thing, you know, which we have to do in conventional angiogram. Many times, if I don't see a competitive flow in a vessel, and if I don't suspect any total occlusion, I accept that graft is gone in conventional angio. I mean, in this 5 years, I came to that conclusion. I accept the graft is gone, like in this case. And another thing, the tight stenosis which you are able to see in CT, in RCA, I just want to know from you, is this RCA is a normally located RCA, or is it coming from anterior part of the sinus?
It is more anterior, Sharath, actually.
Yes.
It's from the same
Yes.
sinus, definitely, but it is definitely
Yes.
anterior.
But from anterior aspect of the sinus.
Yes.
This is
anterior.
another thing which I observed in many cases. Wherever your RCA is anterior in origin, we tend to miss ostium. We tend to miss ostium and we miss interpretation of osteal lesions. This is what I have one case example. I think I have shown in that art of angiography presentation, where we missed, patient came with class 3 angina post bypass, and conventional angiogram was done, and there was a lesion in the RCA ostium, so stenting was done. And post stenting, within 3 months again patient came back. I mean, he had similar symptoms after stenting also. So we did angio, and then I did an IVUS. So IVUS showed angio, I couldn't make out any lesion. I had a suspicion, but I couldn't able to say that this is a tight lesion. When I did IVUS, there is a tight lesion like this. And again, the origin of RCA is anterior. So in an anterior origin of RCA, we may tend to miss osteal lesions. So I think this case, reinforces my idea. I mean, the thought which I had all these days. Over to you, sir.
Yeah, so just role of CT, established role. It has an appropriate index of about 8 or 9 post bypass. I'm involved with one of my fellows where we are doing CT angios for all comers post bypass 1 year. We are seeing about 95% patency on the lemma, and the couple of cases we've done about 150 cases right now. And just offhand sharing data with you, the vein grafts approach about this is 1 year post 1 year bypass data, post 1 year CT data, and the vein grafts are coming to somewhere 55 to 60%, somewhere in that range, and the radial graft being around 70. The lemmas which I've seen, just a couple of lemmas I found occluded. I found that 50% of them, if you look at the native vessels, that is the ostial LAD, ostial circ, and the left main, are actually mild lesions. That means it is not a lemma problem or a surgical problem, but it is a cardiologist or us who have been referring for bypass without correct or accurate evaluation of the left main, just like you've been talking about. So this just wanted to share my experience with you.
Yes, sir. I mean, it is again an eye-opener, I think, for all participants. And this was quite well documented. I have seen a good number of case reports in JAC about the same thing, about LMCA lesion.
Because in every patient where the lemma is occluded because of a surgical problem or a lemma problem by itself, the native vessel, because of competitive flow, just shuts down and gets severely calcified. So when I see a good looking LAD circ or left main, lemma gone, I clearly know that the assessment was an issue. So this just want to share my experience with the group.
Yes.
So I think we have come to the last case for the day, and I'm sure you're all quite tired, but anyway, I'll go with this.
No, we are enjoying your cases. We are enjoying your cases, and I mean, it is very illustrative because you gave all indications without saying an indication.
Yeah. Okay, so I'll just do this and then we can.
Indicates is an indication. And that's what exactly we wanted also. Okay, sir.
Yeah. So 71-year-old lady, angina, class 1 to 2 since 1 month, just started on medication. She's diabetic, hypertensive, LVH on the ECG, LV function is fine. And since she had angina 71, she went ahead and had an angiogram. So these are the images. I have the videos. So this is playing. You can have a look. This is the RCA. Pretty okay. left system. So this is again RCA, PDA. I think there's a mild lesion distally, but we can discuss that. So, repeated attempts, and I'm going to show you one more attempt. You'll have to believe me on this. This was, I think, the last attempt. Multiple catheters, multiple views, and we just couldn't get the left system. This is again, somebody referred to me, so I'm just giving you the what his view was. Multiple catheters, multiple views, just couldn't get the left system. So finally, he just gave up. A lot of contrast, and a lot of time later, he just gave me a call and said, "Can you just find the left system for me?" So Sharad.
Yes, sir. There is in your last injection, there is a small vessel which is visible. Only one vessel is visible.
Yes, agreed.
One vessel is visible.
But
yeah, and
again,
this,
this
is an aleocaudal view. Am I right?
Yes. Yes, aleocaudal view.
It looks like aleocaudal, and it is going anteriorly away from the spine. That could be an LAD.
Yes.
Possible. Possibly.
Yeah. But still, based on that one picture, that was the last picture, incidentally.
Yeah.
We were in no mood to make a diagnosis based on that. So
yeah, it's very difficult.
It was a tough patient, and he just gave up and said, "John, just deal with it." Patient came over 2 days later. I just wanted to make sure that she was well set. And 8 seconds later, we get this unbelievably good picture of the, I'm just going to go through it for the rest of the people not used to it. So these are posterior structures. That will be the left atrium and the pulmonary veins. That's the aorta for you. I've labeled it. And that's the pulmonary artery snaking in between. You have the right coronary sinus. With the right coronary, you all saw that very nice, large right coronary. And coming in from the RCC is a long left main from the right sinus. And exactly interarterial course, that's why I didn't cut off the pulmonary from there. I got another picture between the aorta and the pulmonary artery. So an anomalous origin of the left system. Now this is a very beautifully sort of cut out image that I have for you. I've removed the pulmonary artery and other vascular structures to show you the independent origin of both the vessels. Both are coming from the right coronary sinus. And you can see the left main coming off in between interarterial course between the aorta and the pulmonary artery, snaking out. These are VRT images. This is just a bird's eye view after the branch, just to show you how it looks. The left main and the long left main with the interarterial course. And this is the actual MIP images that I've constructed for you. Mild RCA disease coming from the right coronary sinus, some calcified plaques, non-obstructive. And here you can clearly see between the pulmonary and aorta, you find the left main coming out, long left main dividing into the circ OM1 here. And in the other picture, you can see the LAD. I think you guys saw that with a mild ostial plaque, borderline ostial plaque there, and moving out. So, this is clearly showing the origin from the right coronary sinus cusp and then coming out. So, little unusual, but not too unusual for me. I've seen a lot of these anomalies. We published about our series of, I think we got about, I think was it 4% or 3.5% of coronary anomalies in our 8,000 series. We have just sent to Indian Heart Journal. Just in the last stages of publication. So that was a very interesting view. What do you think, Sharad, before we go to the management part?
Yeah, it's as we already discussed, coronary anomalies is definitely one indication, where we may have to end up in doing CT angiogram after conventional angiogram. But I would also say, there is a method to fish coronary. See, if you are not getting a left coronary, so you just give a left sinus injection in LAO. That's the first thing which we have to do. Next, come to RAO and put your catheter anteriorly in left sinus, give second injection, and still if you don't see, then take a catheter into right sinus and put it into anterior in RAO and give another injection and see. So this is how you have to fish your left system. If we can follow this method, you may end up in making out. We may need not send patient to Johan sir.
Don't give so many of these tricks, Sharat. That's going to be bad for business. Okay.
But
So,
one thing, sir, despite I do angio, there is a problem for me in this case. See, in all such cases where the coronary is originating, almost like, originating, and the immediate course is parallel to the aorta, not perpendicular. For participants to understand, you can show the section, the bird's eye view. Yeah. So this, see where your coronary is almost going parallel to your aorta. These are the cases where it is very difficult to interpret lesions in the ostium and lesions in the proximal part of the LMCA. It would be tough to, even if I do conventional angiogram, if I find something, because here again the ostium is oval in shape. Am I right, sir?
yes. Very true.
Ostium will be oval, and there is a bend immediately after ostium, which may appear as a lesion in your conventional angiogram. This I have observed quite commonly in abnormal RCA origins, which is coming from left sinus. And the similar thing also happens in this. So even if I do conventional angiogram, I may end up in CT angiogram for this case.
Yeah. So
that's what I feel.
Yeah. The other issue, Sharat, which I'm going to discuss, this lady had a little bit of angina. She has some lesion in the ostial LAD, as you can see. The circ looks all right. The origin of the left main, as you said, again, oval shaped with compression. So would you go ahead, we can just leave the REMA to RCA for the time being, but would you go ahead and send her for a CABG, this patient?
What is the age of this patient?
71-year-old.
She's 71-year-old lady. 71.
Yeah, I have read one article wherein this anomalous origin of RCA from left sinus or a left system from right sinus, if they manifest within 30 years of their age, then you can apply. The problem is because of anomalous origin. If the presentation is beyond 30 to 40 years, it is very unlikely that it is because of anomalous origin. There should be something else.
One more doubt. Can I?
That's what I could recollect.
Yeah, Sharat, I'm just going to give my experience also.
Yes.
And this is something, again, they just sent recently for publication. It's about 15 cases of this is pure RCA from the left sinus, because that's just something we see so much of. This was really an outlier case just to make things interesting. But the run-of-the-mill cases I get is, again, as you said, I get it from the 25 to 40 range, people coming in. Many of them completely asymptomatic. And I have 15 of these patients who have a true malignant course of RCA coming off from the left sinus, snaking around interarterial and supplying the right side. Now, I've done MIBIs for all of them. I've done MIBIs for all 15 we sent for publication. More than 70% of these patients, had negative MIBIs. That means no inducible ischemia. Now, simple hypothesis, I know it's a very small group of patients, and this has been corroborated with some other researchers, is we are also looking at how distally or proximal does the RCA, and remember, this is only for the RCA. So if the RCA is going to come up a little higher up, then there is the muscular pulmonary artery which would compress it in systole. Whereas if it comes a little lower down, let's say at this point, at the fibrous point, then the compression is less. And many of these patients also didn't have high-risk features like you described. A slit-like orifice was not there, and acute angulation was not there in this particular group. But again, this is just a small person experience of 15 cases where despite so-called malignant interarterial course, I have told the referring cardiologist that wait, keep on beta blocker, manage this patient. The maybe is clearly negative at good meds or with adenosine for that matter. At this point of time, based on whatever data I have last, we have not lost any of these 15 patients. So this is also corroborated by some other investigators that except for left coming out from the right, it is a good idea to do a maybe scan or a dobutamine for these patients. Maybe scan more preferable because you get better sensitivity for these patients. So in this case, we did an adenosine and it was actually positive in all the 3 coronary territories. So bypass has been planned for this lady. So this is just some of our other experience. I'm just going to show this quickly. So again, another patient with left main coming from the right side, but here it is anterior to the main pulmonary artery, anterior with no interarterial course and dividing into the LAD in the IV septum and the circ in the posterior AV groove. So this is a benign abnormality, and this is another benign abnormality that we see fairly commonly. The left circumflex coming from the RCC, snaking in between the aorta and the left atrium, and then supplying the infralateral wall. Again, a benign abnormality because the left atrium is a rather fixed structure and there's no ischemia in these patients. And of course, this is the kind of patient that Sharat just described. A right coronary coming from the left coronary cusp, acute angulation here, slit-like orifice, and snaking between both the great arteries with narrowing as well. And this would certainly, in my series, this was the kind of patient who had a positive maybe. So this is the kind of classical, intra-arterial malignant course that you would see. And this again is another patient from our series where this is the angiogram. Actually, a root angio was done. Really couldn't make out. Obviously, we didn't follow Sharat's method. And that's the faint outline of the vessel that you could see. And very beautifully, this patient has this right coronary coming from the left cusp, snaking between both the great arteries and going down. The other thing I would like to just say in response to what Sharat said, and I think that is relevant, is that even if you were able to hook this anomalous artery, you would still end up doing a CT. And the reason is that although you would see the course, you would never be able to tell whether it is actually between both the great arteries or anterior or posterior to anyone. So I think CT is one of those definitive indications when you're suspecting an anomalous vessel. So even if you do cannulate them and get the origin and thing clear, you would not know whether it's an interarterial course or not. Sharat, your thing from there?
Yes, sir, I accept that. But you can identify whether the artery is compressing or not. In these patients, you have to take an arrevocranial view. Arrevocranial, the view which we never use for right coronary artery. Take arrevocranial view. So in that view, see, you can at least see whether the artery is getting compressed during systole or not. No other view you can see that. You can try that view, but indirectly you can conclude if the artery is compressing during systole, we can say it is mostly in between the 2 great arteries. If it is not compressing, you can as well conclude it is not in between 2 great arteries, or it may be there, but still there is no physiological effect on the artery, coronary. That's what we can try. But obviously, CT will give you more illustrative or more, conclusive pictures on its location and everything.
Yeah. The other thing I just like to quickly discuss is the surgical technique, especially in younger patients. We are recommending our surgeons to translocate the coronary and fix the button in the right place rather than do a bypass, for the same reason which Sharat alluded to previously, because you're going to have competitive flow. And we have had a couple of our RCAs, the grafts getting occluded in those patients. So translocation of the thing and putting the button, the coronary button in the right sinus, I think is a very important surgical thing that you must insist your cardiac surgeon on doing. Sharath?
Yeah, sir. That's true. That's true. Otherwise, your graft will go off.
Yeah. Otherwise, they take it for granted that they'll just put a graft and get away, which is an easier thing to do.
Yes, sir. I think this is a very important take home for all our participants.
So I think I'm tired now. I've never been talking for more than 1 hour because I get 10 minutes only in most talks. So just want to thank Sharath and again all of you who have been very patiently listening to me. I again apologize for some of the interventional things that I've been talking about because I'm really not a great interventionist, but this is just to stimulate opinion. So I'll quickly sort of complete by just running through some good take-home messages that you all should take home. And that is CTA is a technique which is non-invasive, it's safe for intermediate risk CAD at the moment. That's the label indication. It's a very useful technique in post-bypass where graft anatomy is not clear, not known very well. And it's a useful technique in chronic total occlusion to assess vessel anatomy and also viability in the same sitting. So you get to know the collateral, you get to know the distal vessel. Most important, you get to know the path, the route, that is whether there's calcification along the route, is there thrombus or fibrous material. So you can choose your material, your armamentarium for doing the CTO opening in a better fashion. And CTA is an emerging tool in the diagnosis and risk stratification in myocardial rupture. A number of people outside this country have accepted some of my work, and especially this area. I think it's very important and interesting because we're getting these patients, late diagnosis, late thrombolysis, coming in with pericardial effusion. What do? Most of us don't do contrast echoes, and I don't believe that's the way to go. So I believe CT, which is just next to the ER in most hospitals, is a great tool to use and to rule it out. And CTA is an alternative tool, obviously not the best tool, but an alternative tool if you want a cheap, non-invasive way of assessing a left main stenosis. So with this, I just want to thank you once again. And it was great presenting these cases, and I hope you liked it too.
Yes, sir. I think now probably you have to answer, our participants' questions.
My point.
Yeah, Sridhar Nagraj.
Yeah. Hello, sir. And Sridhar. Hello, sir.
Yes, yeah. I can hear you.
Yeah. So it was a nice presentation. Most of all, usage of CT in during interventions. But I have a basic question and diagnosis of coronary CAD. So now we have increasing surge of CAD in young patients. So they do come, and many of our relatives they come up for screening for CAD. So most of the time we do ECG, TMTs, and we say there is no problem, but they keep on pestering us. Is there any other investigation to rule out CAD? Ultimately, we end up in sending the patient to CT angiogram. So here I have two questions. One is, when we do a when we do a CT scan, is it enough to get a plain CT and know the calcium scoring, or we need to go ahead and do a coronary angiogram in total? Second question is, what are the implications of having a calcium score 0 or higher? If it is 0, can we just leave the patient and say that your total risk is almost nil, or atherosclerotic burden is almost nil?
Yeah, I'll just try to answer those two questions. So the first technique is, number one, CT is a great tool. It's a fairly easy technique to do. And I would believe it has a huge negative predictive value of nearly 99% if done well. And as cardiologists, I think it's very important when we send patients for CT, we need to know where we are sending and what is the expertise of the lab, because you can get some really dreadful pictures, which does no good for either you or the patient. And the second thing I would like to reiterate is you must get that patient's heart rate down as a cardiologist. That would be our prime function, beta blockade, ivermectin, diltiazem, whatever it takes, because most of the labs are run by radiologists and their experience with either of these three drugs is quite low. So I would like to beta block that person well before I'm sending this patient. That's the first thing. The second thing is I'm going to give you my data, which I have. We have just about completed 12,000 cases. It's been a decade for me. 2008 I started. So in 12,000 cases with calcium score 0, I've had, I think about 10% patients, 10% out of 0. I'm talking about calcium score 0. This is by data. 10% of my patients have had atherosclerotic plaques. Atherosclerotic plaques, these are non-calcified plaques, which would be invisible on a calcium score. And out of that 10%, about 20% of that 10% actually had interventions to go with it. So, so you're looking at not a large number, but a number of patients who actually with a 0 score went and actually had an intervention. So while it's great on a population wise, saying that 0 score means a lot of safety, it means a lot of safety in a truly asymptomatic patient. Not very true when you're looking at symptomatic patients. And I'm saying a wide variety of symptoms, right from atypical to, anginal pain. And of course, our data is all heterogeneous. But I've had a sizable number where 0 score did not equal complete safety. So in my lab, unless somebody is very particular and they've come in from the West and, they just want a calcium score and go away, I insist on all my patients getting the full scan. It takes another 5 seconds, nothing more, a little more radiation. So our calcium scores are done at about 0.5 millisieverts. And a traditional patient, not too obese, gets about 3.5, which I think for a diagnosis of CAD in the long run, when you rule it out completely and you've got almost, now the present data is almost, 3 years for a non-smoker, non-diabetic, and maybe about 18 months to 2 years for a diabetic. The data on smokers is not very clear. I think it's worth the radiation, to go through the whole scan. So did I answer that?
Yeah, you almost, sir. I think I have now clear answer. So particularly in asymptomatic patients, not just calcium scoring, but a complete CT angiogram is necessary to completely rule out CAD.
Yeah, I would think that younger the patient, more acute the symptom, we have found a fairly large proliferation of non-calcified plaques, which are completely invisible on a calcium score. So I'm actually more careful when the patient is younger with symptoms.
Right. Now that you can assess the plaque nature also, vulnerability of plaque also. So CT angio would be better rather than just going for a CT calcium.
Yeah. We are now looking at plaques very differently than what we used to look at. So while we initially looked at calcified, partially calcified, and non-calcified, now we're looking at the four dangerous thing, which is basically somebody with lipid-rich plaque, somebody who has positive remodeling, somebody who has spotty calcification, and the fourth being somebody who has sort of a very eccentric kind of plaque, napkin ring kind of plaque. So these 4 quartet, I call them the dangerous quartet. When we see them, we keep these patients under a tremendous kind of a scrutiny, which involves getting the LDLs right down to 70, making sure blood pressures and sugar control is immaculate, and telling this patient that needs to keep visiting us fairly frequently because the surveillance has to be very, very good in these patients, because they have been shown, they are one of the clear things that show that, MI, unstable angina and MACE is not too far away. So we have the ability now to look at that in a good lab. You would find a person who's able to give you some of these characteristics. And I think these are patients you need to keep under tremendous amount of supervision.
I also re-ascertain the fact that the place where you are sending the patient for CT angio is very, very important, because quite often I have seen patients coming with a normal angio report in a atypical symptoms, and ultimately they land up in ACS events, or for other reasons or some other stress test being done, and they end up in doing an angio, we end up finding a lesion. So obviously the place where you are sending for CT is very, very important.
But see, I would, tell one thing. It's always better to see even CT angio by ourselves.
I think that's a very important point, and we have been doing workshops across the country, and I'm maybe going to take Sharat's help to do something here. We've been doing it all over the place, and I've got a dedicated team that we come and do these workshops with the help of GE or Siemens. And unfortunately, we don't get too many cardiologists in, but things are changing. I think it's very important that you don't need to know how to do a CT, but it's very important, I think, to know how to interpret a CT data. I think that's very important, and it puts a lot of onus on us, not leaving it to radiologists and the like, because then they get to tell you whether patient has got disease, no disease, and things like that, which I think is our domain. So one of the missions that I have is to basically train cardiologists not to do, but to interpret CTs and to look for some of these, abnormalities that we've been looking at, and not leave it to the discretion of where you send. Sometimes it's not under your control. I think it's very important to look at the data set yourself. And one of the missions I have is to, spread this word across the country. So I'm glad that Sharat brought it up.
Yeah, I can put my own personal experience in this regard. See, after I started seeing my CT angiograms and started analyzing my CT angiograms, especially in patients with chronic total occlusions, I learned a lot. In fact, now I'm even deciding where I have to go ahead with rotablation. So where I also I can say before which wire will work in this patient. See, many times we start CTO with a fielder wire, but in cases where I see a calcium in the middle of the lesion, so in most of my cases where I saw calcium in the middle of the lesion, not in the walls, in the plaque, so there my fielder never worked. So almost all the times I end up in either Gaia 2 or Gaia 3 or Conquest. So if you start seeing CT more and more, and if you analyze retrospectively your intervention, it gives a lot of insight into your interventional planning. So that's what exactly happens. See, it's very difficult, to for all of us to understand somebody's experience unless you go through it and you retrospectively analyze your intervention. You don't understand the insight which CT gives, especially in a complex intervention.
Yeah, I think that's a very important point, and I'll be happy to work with many of you to get over the sort of initial stages so that you're comfortable with looking at CTs, comfortable at least basic interpretation, and then once you start doing these interventions, having the CT data in front of you, and we have cath labs now where you can actually superimpose a CT data. I think it's going to be a very useful tool for us to get into and get involved in.
Yeah. Nagraj.
Yeah. Good evening, all of you. From Tirupati, myself, I'm Nagaraj, and along with me, this is, I think, it's Vasudev Reddy here, and Bhaskar Reddy also. All of us from
Hi, Bhaskar.
Hi, Bhaskar.
Probably, I think I should put this webcam somewhere else. So I put it now, so that all of us can.
Hope you enjoyed presentation.
Yeah.
I must say this, I learned a lot today myself.
Presentation was
any questions?
It's a long time since I've seen you. A nice presentation, sir. Thank you very much. really learned few
Nagraj
things.
has actually worked with me for some time. He's an expert himself, I think, by now.
You gave me something of 11 months. But yeah, I have some experience of like maybe 3-4 months. I worked with John sir in the Cta Angiogram. At least he taught me how to reconstruct the images, interpret and give the report and all those things. So I have some idea. In fact, one presentation I did at that time in that imaging club, APCSA imaging club, which was more to do with the coronary anomalies and Cta angiogram, how it helps like that. So anyway, it's good. Cta angiogram is here to stay, but the thing is like availability is the issue here. Like for example, here in Tirupati, we have only one center where Cta angiogram may be done, that is SWIMS, but done by radiologists and the reporting is patchy and we are unable to rely on it. So such are the issues here. See, you have everything in hand. It's easier to tell like CT than like maybe MR, but here there are a lot of limitations with this.
So Nagraj, just to answer your question, I am doing short courses, a day's course for cardio. I would like to do it for cardiologists in different places. We've done in Jaipur, we've done one in Lucknow. So we'll be happy to come over, provided you give us the infrastructure.
Sure.
And we'll spend a day with you guys, show you cases, make you go through cases. We have a sort of mini capsule that I've made. So we'll be happy to do that in case that seems to be the problem.
Thank you, sir. I have a question. So regarding viability testing, which you have recommended through this month in the first place, the viability testing through CT, where we are in the present scenario. So you are the best person regarding MRI, PET, and this one, CT, which you want to recommend.
Yeah, so I wouldn't recommend anybody to do CT for viability, just as an independent kind of a tool. Yeah. So these are very early days for CT, and we like to minimize radiation risk to our patients. So my first choice will always be an MR. But if somebody comes in with an unknown kind of heart failure and you want only one investigation to see this patient, I am getting experience now doing CT because I get the coronaries, which is the holy grail for whether there is CAD or not. And I'm getting the wall motion, the function, and viability as well. Now, viability is not good with a 64 slice scanner. It's almost impossible. You need to have dual energy capability, either with a single source or with dual source. We have a dual source, dual energy. So viability, not a major problem for us in just a single run. But anybody working with anything less than that, I wouldn't even attempt looking at viability. So for us, clearly, MR is the winner in terms of viability as cardiologists. In fact, I hardly ever send patients for PET scans or maybe scans for viability alone, as long as the other contraindications are not there, like CRF and things like that. But for me, MRI would be the first choice.
One doubt actually I got in one of the cases in the RCA, we had, I think RCA, we had no blood flow, whether it's antegrade or retrograde flow, LED. If there is absolutely, the vessel is not at all visualized in the antegrade or retrograde, no visualization of vessel at all, do we still need to look at the viability?
Yes, so the visibility, non-visibility, collaterals, no collaterals, to me, at least with now 10 years of experience, is really not an issue because you can get all variabilities or variations of viability. So whether the distal vessel seen, and as Sharad pointed out, we have had a number of patients, osteoproximal occlusion, angio shows a flush occlusion, you do a CT, you get a fairly nice distal vessel visualization. So an angio not showing distal, to me, has no relation with viability. I've seen all variants of it. So if you have a completely occluded vessel, I would go ahead and do a viability by any other method, whichever is convenient, either nuclear, PET, or MR. Did I answer that question?
Yeah. See, mere invisibility of vessel is not equivalent to non-viability.
Right.
It's simple. I mean, you have to explore, that's all. And that invisibility, I mean, you have to say it is invisible, provided you have taken, longer injections, especially, contralateral coronary. You have to spend enough time on injection. So that is very, very important, before you utter that word invisible. Despite all effort, even if it is invisible, then it is always wise to do a CT angio. Even if you want to plan a procedure also, CT angio is definitely mandatory. So, in those patients.
So I have one last question, sir.
Yeah, Sridhar, go ahead.
Yeah, in a properly interpreted CT angiogram, what is the accuracy of percentage stenosis? We often see in the reports 50 to 60. What is the accuracy?
Yes, so I'll just answer that question. If you look at large data, and this is all post 64 slice data, we are coming to near 90 to 95% accuracy in terms of CT angio with vis-a-vis angio. It'll never be 100%. And the reason I'm going to tell you this is because we look at the entire vessel wall included. We look at positive remodeling, which is really not possible on an angio. So our tools are always going to overestimate a stenosis. And for that reason, in most of our meetings and the recommendations is not to give a number. So we give a broad range, 50 to 60, or I give anywhere between 50 to 70. I call it an intermediate stenosis. And I would say that if the patient is not clearly symptomatic, we need to do a stress testing before you go ahead. Anything under 50 to me is mild, and these are patients generally medically managed. And anything above 70 is severe. That patient straight goes to the cath lab. So we don't give a single number. We give a range because it's not possible to assign a number because of the issues that I've told you, that CT is a tool which looks at the wall and the lumen. It's not a luminography. So you cannot compare it with a technique like angio, which is a complete luminography. So that's the reason why it is not really fair to really compare both of them. But when you do so, please understand that these are the various limitations. But as you've seen in the cases that I've shown you, we've had a pretty good concordance. I think Sharath was there from the beginning. I think we had a pretty good concordance in terms of lesion severity, don't you think?
Yeah.
And the other thing I just want to put across, I mean, I've been doing angios a lot, but how many of us are really doing QCA? I just like to put this question across. How many of us are really doing QCA? In fact, I have a BMJ article which I don't mind sending across.
I never used it.
Yeah, I have a BMJ article. Obviously, a radiologist perspective, and it says finally that that are the cardiologists doing QCA on a large scale? And this is a BMJ article, and I can just send it across to one of you. So I think we need to refine our own techniques very well. Make sure we are really quantitative before we are going to say which is accurate and which is not. I mean, I just put this over the forum. I also do angios, and I'm not very particular about QCA. But in CT, we're pretty quantitative. We actually give some real numbers. In fact, I do cross-section analysis whenever it's required in intermediate lesions. So I give the pre, the lesion, and the post, and the length of the lesion to the interventionist. That's what I do in intermediate lesions or severe lesions. So I think we need to be more quantitative ourselves before we really, sort of have this interpretation.
Johan sir, what's your take on this for FFR CT at present scenario with this?
Yes, if I heard the question right, it's about FFR CT. So I've had a chance to visit the home of FFR CT, that's Redwood, California, and it's a great tool. In fact, if you look at all the 3 trials which happen, including Discover and the other 2 trials, there is near concordance, very close concordance with invasive FFR. And the best part is, this is such a beautiful technique. We don't need to give anything extra. We don't give adenosine. We don't give extra contrast. It's just a simple CT data set which you export to a lab in California. Obviously, they charge you for it big time. and you get each vessel FFR. Isn't that sort of amazing? And the 3 trials, you're all aware of them, had near concordance with the invasive FFR. And the best part with CT is you can do something called virtual stent planning. So you can have a FFR which is 0.6. You can interpose a stent. Okay, they have the software tools to do that. And then it becomes 0.9, you know. So it means clearly that if you stent that particular portion, you're going to restore that vessel. So I think it's a beautiful planning tool. Siemens is now coming out with a tool right in their workstation. Possibly it will hit India 2 or 3 years from now. They have just the demo model, which I had a chance to look at. Right now, it's pretty expensive. Everything has to be exported to the US. They have the market, they have the monopoly for that. Canada, there is one of my friends doing it, but again, it's off-label. But if it comes in, I think it's going to be a huge, beautiful tool where after a CT, you're either going to keep that patient on good optimal medical treatment, or he straight away comes to the cath lab and you know exactly which vessel to fix, you know the length, you know the area, everything is done for you. So I think it's a great tool for us as cardiologists.
Yeah.
Sir,
Yes.
I'm Anand, sir.
Oh, Anand, okay.
Sir, it was a very nice discussion, sir.
Dinner is being served right now, and since Sharath is not sponsoring anything online, so.
Sir, thank you for the very wonderful discussions. I learned a lot, and I'm very excited to work, sir. Next month probably I'll be working with you.
Yeah.
I'm posted
That's what
there.
you guys also before you come.
Yes, sir. Sir, and I remember
a lot of drudgery, you know. It's a lot of. In fact, I have relearned mathematics just to keep things. I've learned a lot of mathematics after doing imaging work, which I didn't do as a routine cardiologist. So anyway.
Sir, and I remember a few cases, sir, like in patients with severe AR, aortic regurgitation, where
Anand, you're not audible.
I lost you at that point, severe AR.
Yeah, Anand, there is some problem with your mic. Yeah, it's okay. I think it's okay.
Yeah, I think I'm done.
Yeah.
Good. Thank you.
Yeah, it's a great presentation. See, almost 15 of us are still sticking to, system. It's a great presentation, and there are many eye openers in your presentation. Myself learned a lot. Probably, I feel Restall also learned a lot. Yeah, we can have one more session on this interpretation of CT, basic interpretation of CT. Maybe after a couple of months. Surely, sir, we need more and more such presentations from you. So
yeah, Sharath, I'll be happy to do that.